A very good morning to everyone. It is a pleasure to be here with all of you. Uh, and my thanks to Partho and the team of Northeast Respicon for inviting me here for this talk. So in this talk, we'll talk about impulse oscillometry, and we'll try and see why do we need a new test, right? We already have a spirometry in place. Then why do we actually need an impulse oscillometry into our armamentarium, and how does it fare? We'll talk about some basic physiology. Uh, how does it work? The benefits and the limitations, and the indications where it is helpful. We'll also talk about some clinical utility and what is the current place in practice where oscillometry should be considered in the management of children. Now, before I go on to this, I'll briefly in the next few minutes talk about asthma, because chronic cough and asthma remains the most important indications for doing a lung function in the pediatric age group, and that is the place where oscillometries also do help. Right. So this is the GINA definition of asthma, and it talks about symptoms and it talks about lung function. So it talks about the presence of cough, wheezing, shortness of breath, and chest tightness. Right. I'll not go into details of this definition. Now, if these symptoms are there are multiple of these, they're variable over time and over season. There's nocturnal worsening and they're worse with activity. Now, in addition to this, Gina talks about getting the lung function done. It talks about classical spirometries. So if you have low FEV1 by FVC ratios and you show reversibility in any form, you will label that as asthma. Now, that definition doesn't classify between adults and pediatric age group, right? Now, we all know that asthma is not, is not something which is, very black and white. So you have children who present with those classical symptoms and will form the peak of the iceberg, right? But there would be children who present with partial manifestations like recurrent cough. They're not wheezy, so not sure whether it is an asthma. A recurrent wheeze is no cough, only a nocturnal cough, only a persistent cough, only an exercise-induced cough. So there might be partial or form fluster manifestations of asthma, which are sometimes difficult to diagnose. Now, with this background, we all know that although we have been talking about lung functions in detail in many conferences, PFTs are hardly done in clinical practice. That is the truth. Why? But why? There are practical things associated. So most people would say that, how does it add on to your clinical diagnosis? You have clinically diagnosed that this child has asthma. Why should I get a lung function done? And then there would be situations when a lot of children may not be able to perform a lung function. If a child is very well in follow-up, why should I get a lung function in follow-up? Does it really help me in practice? And there are other practical problems. Fine, you're talking about lung function. Where should I get it done from? And who bears the cost, right? So there are reasons why in pediatric age groups, lung functions are not done. And there are some practical issues to that. Now, lung functions, when they should be done, and what is the practical answer? So ideally, they should be done in all patients where you are suspecting asthma. Why? Because reversible airflow obstruction is the hallmark of diagnosis. And it is also very helpful in assessing the degree of obstruction and defining control. So ideally, they should be done in all patients. But if you have a patient who is otherwise, falling into a clear clinical diagnosis, even if you're not doing a lung function and putting that child on treatment, it's fine. But there are clinical situations when It has to be done. These clinical situations are when it is clinically ambiguous, so something like an asthma mimic. There are partial manifestations of asthma like cough variant asthmas or exercise induced bronchoconstriction. Here, you're not sure whether it's an asthma. The parents aren't sure, the doctor aren't sure, then how would you start them on treatment? Asthma, which is poorly controlled despite adequate therapy. So you have to get a lung function done to see what's going on. There is a role of getting annual spirometries done, especially on children who need long-term treatment to assess control and to follow the trends of airflow limitations. And there are groups of patients you will always get who would not agree to what you are saying, and they want a diagnosis with certainty. And if you prove with a diagnosis that there's an obstruction and there's a reversibility, people will accept the diagnosis. And once they accept the diagnosis, the chances of accepting treatment are also quite high. So that's how I would put the utility of doing a lung function in the perspective of chronic cough and asthma. Now, it brings us to the point that we're doing conventional spirometries, but conventional spirometries have some limitations, right? So these definitions have not been fine-tuned for children by GINA. So in general, in an older child, you can get a spirometry, but we do understand that it requires a forced expiratory maneuver, right? So you're able to do a spirometry in children more than 6 years of age, but again, 15 to 20% of children, even more than 15 to more than 6 years of age, are not able to perform a good quality spirometry. Now, there are situations when you can do a spirometry even in preschool children. So there is data available. You can do that, but it requires a lot of coaching. We can use animations to help us, but still the chances of having good quality curves are not very high, right? And we also need to remember that there's a group of patients where they have asthma, but the spirometries are normal, right? Now, that brings us to the point that what was needed. So what we need is a test which is effort independent, and you do not need any special breathing maneuver for that. So you don't need need to ask the child to blow forcefully till you've reached to a forced vital capacity. It just requires a passive cooperation, and hence you can test younger age group, and you can also test those older age group who are not able to perform a spirometry. So is that possible? Well, that's possible, and that brings me to the current topic of impulse oscillometry in children. So that is what the standard equipment looks like. The few brands which are available. So this is from the Care Fusion, which we have been using for a longer time now, since the year 2012. But all of them nearly works on the same concept. So you have a loudspeaker here, you have a resistor, you have a pneumotac, and you have a transducer. Now this loudspeaker produces noise of various frequencies, and this noise passes through the resistor to the pneumotac. Now, the patient, the child, holds on to the mouthpiece and is breathing. And what this pneumotac is going to catch is a superimposed tidal breathing of the child on the noise of various frequencies, right? So it is a superimposed breathing with the noise of the various frequencies, which this pneumotac need to catch. And that signal is taken by the transducer to the computer, and then you get your values, right? And this is again the graphical or a cartoon representation of what I have been talking. Again, the same thing. Now, the principle of this oscillometry is that uh, the sound waves which are produced by the loudspeaker goes into the respiratory system of the child, and uh, depending on the frequency of the sound waves, they would traverse to a distance, right? So frequency which are lower, so classically the 5 hertz to 40 hertz is something which is done. So the 5 hertz actually penetrates from the larger airways and reaches up to the smaller airways. On the other hand, sounds of higher frequency, so for example 20 hertz, will gradually damp out and will not be able to reach the smaller airways, but will reach to only the larger airways. And these differential frequencies help us to understand the various respiratory diseases in pediatrics. Now, which age group can perform an impulse oscillometry or a forced oscillation? Well, you can do it in children more than 3 years and above. You have data available in children more than 2 years and above. Between 2 and 3, they become very cranky. So we usually take it as around 3, but you can do it in less than 3 as well. It hardly needs any cooperation from the patient, but they still need to hold on to the mouthpiece and should be able to tolerate a nose clip, which you have to put on them. Right. So as I said, it does not require a lot of cooperation from the end of the patient, but still it requires some of it. They don't need to expire forcefully, but they still need to agree to sit there, allow a nose clip to be put, hold on to the mouthpiece, not crying, and you have to hold on to the cheeks like this so that the sound waves are not dissipated from the cheek and lead to artifacts. Right, so the patient is asked to breathe via the mouthpiece, which is attached to the pneumotac, and the patient has to breathe normally. So it requires a tidal breathing maneuver. So usually around 20 to 30 seconds of maneuver is required. It can be end manually, but usually these machines have an auto cutoff, which is there. After around, some machines have 20 seconds, some have higher. Right. What constitutes an ideal or an adequate test? So you need 3 or 5 iOS replicates to be done to ensure that they are reproducible, right? The same way you do a spirometry. Each of these tests should be without artifacts. So there should be no air leaks. There should be no swallowing artifacts. There should be no breath holding or vocalization. And it needs, you need to be trained on interpreting these curves, because they are a bit different from the usual spirometry. So once you start doing them, you will realize how these artifacts appear on the graphs. Now this is a normal display what you get. So they're absolutely different from what you get in a spirometry. So what you get here is something known as reactance and resistance. And as I said, it shows on various frequencies. So resistance on 5 hertz to something like 40 hertz, and again reactance from 5 hertz to 40 hertz. It is there, and the graph shows the various frequencies. And as you can see, this is the red graph, which is your resistance, and this is the blue one, which is your reactance. Right. Now you also get other additional parameters. So there's something known as the Goldman's triangle, the AX values, which is thought to be one of the best values, which reflects changes in the degree of peripheral airflow obstruction and closely correlates with the frequency. And there's something known as a frequency dependence. So the peripheral airflow obstruction is highest at low oscillation frequency and falls with increasing frequency. So that is what is the frequency dependence. So this is the part which is called as the Goldman's triangle, or the AX, and the frequency at which the reactance curves meets zero is called as the FDR, or the frequency. Right. Now, what constitutes an abnormality? So now, as we do understand that if there is obstruction in the airways, and the resistance is going to go up. So anything less than 140 is considered to be normal. Uh, if it is somewhere between 140 and 200, we call it as mild. 200 to 250 as moderate, 250 to 300 as severe, and more than 300 as very severe. So this is an arbitrary classification which has been recommended by few of the societies. Now, for reactants, you do not have percentages. You calculate it as predicted minus 0.15 as normal. If it falls between 0.15 and 0.3, you call it as mild. And likewise, you have values for moderate, severe, and very severe. So this is the way you classify reactants. Now, one of a very robust criteria for which IOS is something which is known is the bronchodilator reversibility. So you're trying to look at the initial curves and then the post bronchodilator curves and see how the resistance and the reactance would change. So a change of something like 20 to 40% in the R5, 15 to 30% in the R10, and approximately 40 to 50% in the AX value is what is universally classified as a bronchodilator reversibility. Now, how do these curves appear in various disease states, right? So if you look at the resistance and the reactance curves, right? So so normally this is the resistance graph, right? Now, if there is peripheral airflow obstruction, which is usually what happens in a child with asthma, the resistance at lower frequencies would go up, as we have talked about, and the resistance at higher frequencies, they're not so much raised. So there's a difference in the frequencies at lower frequencies versus higher frequency, and hence this graph appears to be something like this. On the other hand, if it is a central airway obstruction, then it is going to be almost similar at all frequencies. And we have talked about this physiology in the last few slides, right? So this is how the resistance curves would appear. And in the reactance curve, in peripheral airflow obstruction, the graph would be pushed down as shown in this graph. Now, there are still flaws and fallacies which we know. So there's an upper airway shunt. So if you don't, fix the cheeks or hold the cheeks like this, then because of the movement, there's an upper airway shunt which is called. Inability to relax. So a lot of children are anxious when the test is done, and hence the values can be quite different. There can be irregular breathing or hyperventilation, because a lot of children would start breathing fast when they hold on to the mouthpiece. So they have to be calmed down, and only those maneuvers should be taken. They can be leak around the mouthpiece, because some of the younger kids are not able to hold on to the mouthpiece that well. And there can be an inadequate seal with the nose clip, and hence there can be nasal breathing, and it can lead to problems. Then sometimes they might be talking simultaneously, that is vocalization, then swallow artifacts. So if they try and swallow at the same time, then swallowing leads to transient glottis closures, and that is a problem. Then coughing in between jaw movements. Sometimes they're trying to chew when they're breathing. So these are the flaws and the fallacies which are there with the IOS, and gradually as you do these over time, you will get to know how to sort them out. Right, now let's talk about some clinical utilities. We have talked about the basics, right? So this is a 5 years old child who has a suspected asthma, and you tried a spirometry, but the spirometry failed. Now, these are situations when then your oscillometries can come into play, right? So in this child, what we found, the R5 values were significantly high. The R20s are not as high. And if you simultaneously look at the graph, so you have a pre and a post bronchodilator curve. So the blue one is the pre, and the red one is the post bronchodilator curves. Right. Now, as you see that the graphs have gone up, so that is the classical shape of a peripheral airflow obstruction. And once you give a bronchodilator, you find that there is some change, but we do understand that change was not as much as what you would take for a classical reversibility. But there was a definite airflow obstruction which was documented in this oscillometry reading. Now, this 3 years old has chronic cough, doesn't have a wheeze, right? So you're not sure about what the diagnosis is. You can have multiple diagnoses, which we can talk about. It can be allergic rhinitis, postnasal drip, sinusitis, bacterial bronchitis, and so on. So either you treat this child empirically, but sometimes you aren't sure, the parents aren't sure, they're not willing for that. And if you look at this, then the impulse oscillometry sort this out. So raised R5 values, and you find that there's a significant difference post bronchodilator. So 35% improvement here and 60% improvement in the AX values. So again, you've made a diagnosis, and it helps you in treatment and in follow-up. Right. Now, this is another situation. So the 6 years old child has suspected asthma, has frequent symptoms requiring nebulizations. Now, the lung function you have done in the spirometry is absolutely normal, right? And there is no obstruction, and there is no reversibility which you document. But once you do an oscillometry, you actually find that the resistance values are high, the R5s are high, the R20s are not very high, and you find a clear reversibility to 40% change in the R5 and 62% change in the AX. So these can be situations when, again, your spirometries have not shown obstruction. The child is still symptomatic. You feel it is asthma. You do not feel there's an alternate diagnosis. And your oscillometry shows obstruction. And we'll talk in a minute why that happens. Now, there's a phenotype in asthma which is called as small airflow, small airway asthma phenotype, or small airway dysfunction. Now, people have talked about this and realized that there were groups of adults and children who were not well controlled. So they were symptomatic, but they have normal lung functions, right? And that is when people started looking at the smaller airways. Now, these smaller airways are difficult to picked up with a spirometry. There are ways you can look at the smaller airways, and for example, FEF 25 to 75 has been one, but the problems are that it is not a very robust criteria. Then people have started looking at the AX values in the oscillometries, and there are some other ways people have looked at, but that appears to be a bit more complex. So oscillometries have been a good modality to look at this phenotype of asthma, where the smaller airways are involved, which are conventionally not picked up by the spirometries, but they are very well picked up with an oscillometry because of the capacity of oscillometry to differentially evaluate the central and the peripheral airways. And this is a meta-analysis from GINA, where they tried to look at the small airway dysfunction in asthma, and they have seen that across GINA 1 to GINA 4 and GINA 5 categories, how does it show you? And if you look at these values, then it was approximately 30% in GINA 1 versus approximately 70% in GINA 5 category. And they have used spirometries, which is FEF, as I talked in the last slide, FEF 25, 75. They have done plethysmographies, oscillometries, and multiple breath washouts. So these are the modalities which people have used to evaluate small airway dysfunction. So 20 to 40% of children with asthma have small airway disease. Uh, it has also been seen that children with control asthma who have increased IUS values, they are at risk of losing asthma control if the drugs are tapered at that point of time. Because the spirometries are normal, they're looking quite good, they're asymptomatic, and we tend to decrease the medicines, right? And IUS might be a reliable and non-invasive method to assess asthma control in children. And AX, an improvement in AX is something which is a good index to evaluate in follow-up to understand whether we can taper them out, or they need to be continued in the same dose, or we need to increase the dose. So we did a DNB thesis of one of our students at BLK Hospital, and we got to learn a lot from this thesis. So what happened previously was that if a young child came, we did this oscillometry. For an older child who was able to perform a spirometry, we just did a spirometry, and we forgot about the oscillometry. But we got into this thesis mode, we were doing both, trying to compare how does it fare against each other. So we took a set of patients, approximately 100 patients were taken. The preschoolers and school age children, and as you see, in the preschool children, only 50% of them were able to perform a spirometry, and this was using an extremely good software from CareFusion, good animations, and doctors doing and pulmonologists doing spirometries themselves, and still only 50% could do that, right? So the failure rates were quite high for spirometries, and approximately 5% were not able to do spirometries in children more than 6 years of age. So there were groups of children with suspected asthma and known asthma in follow-up, and they could be classified as controlled, partially controlled, and uncontrolled, taking into account the GINA definitions. Now, what we found was that the yield of oscillometry was quite high, something like 66%. Spirometries were quite less, the diagnostic yield, right? And if you add them, so if you add them together, then the yield is significantly high, something like 72%, right? So what we have gradually learned over time is that because we do it in the same equipment, the same software, we tend to use both these modalities together, and they give us additional, inputs on what's going on with the patient. So we now tend to do oscillometries first, do a spirometry. It hardly takes us 2 more minutes to do that. And then we try and look at the reversibility and report both of them together. As we have gone through, so we might have done approximately 400 to 500 patients after the thesis has happened. And we have realized that there are groups of patients where the spirometries are abnormal, but the IOS is normal. And the groups of patients where the spirometries are normal and the IOS is abnormal. So as we go along, we have learned that, asthma is not just one phenotype, the different phenotypes of asthma, and we are learning about these phenotypes more with the lung function over these years. So what is the place of impulse oscillometry in pediatric respiratory practice as of now? So young children less than 6 years, suspected asthma, chronic cough, a good indication to do. Older children not able to perform a spirometry, and older children where spirometries are normal, you can get oscillometries done. We might be doing for all patients, but that is not what I'm trying to recommend. It is something of our personal practice, where because we have the equipment available with us at our clinic and hospital at both places, and our practice is exclusively respiratory and allergy. It is a useful modality to assess the level of control. So oscillometry has been found to be, equally sensitive compared to spirometry for diagnosis. But as I said, there are caveats to these, as we have talked about. It is a good option where children not able to perform a spirometry. And there are situations when we have found it is more sensitive, even in children where spirometries were done, but that was normal, and you found the IUS found obstruction. So a lot of children where we found this because of the phenotype of small airway dysfunction. And it has been a good tool in evaluation of under 5 wheezing and asthma, as I've shown you a few cases. But it is not fraught without problems. And we do not have any reference equations for India's at the moment. Uh, we do not have, very clear data even on reversibility, the repeatability of the test, that if you do it now, if you do it after 6 hours, if you do it after 2 days in the same child, how much variation is something which is acceptable? Is it like 5% or 10% or 15%? That is something which we don't know. And we also do not know what is the exact cutoff for bronchodilators in normal healthy children, because we don't have normal healthy children reference equation, and the response usually that is going to happen. So as you had seen, the cutoffs were between 20 and 40%. So that's bit into a vague zone. What we also do not know is the utility in other obstructive disorders such as cystic fibrosis and non-CF bronchiectasis. The utility in distinguishing various phenotypes of preschool wheezing and hence deciding controller therapy does tell you about obstruction, but it doesn't tell you anything more. And we do not know the utility in restrictive lung disease and mixed disorders. That is something which we need to study more. So I'll end here with some take-home messages that PFT and the iOS is something which is coming up. It is a useful modality, and it uses a tidal breathing maneuver, and it overcomes the major drawbacks of spirometry. The major utility at the moment is children who present to you with chronic cough, suspected asthma, diagnosis, and asthma follow-up. It does need a significant experience, and it has a high learning curve. It takes a bit of time, 6 months to a year, to get used to it, to understand what's right, what's not right, what's going wrong. And what I would say is that it should be at the moment left for people who are doing pulmonology practice, and it is going to be helpful for those centers. And most people who are interested into respiratory practice should consider spirometry as the standard test uh, as of now. So thank you very much. And again, I would like to thank the organizers for inviting me for this talk.